All right, let's continue with female physiology. We've done the first 10 days, which is estrogen controlled. Now we're going to make our transition. After estrogen does its three actions, that's ductular growth at the breast, proliferation of decidual functionalis at the endometrium, and thin out the cervical mucus. Then you have to have feedback. Okay, close the door down. All right, so now you got to have feedback. Remember, feedback inhibition is the rule in all of physio and biochem, whether they wrote it or not. You're supposed to know that. So estrogen will then feedback to inhibit the pituitary for FSH, and estrogen will feedback to inhibit GnRH because both of those control them. What if I could block that feedback? So if you look at the this graph here, it's like the first 7 or 8 days, estrogen is going up. And then it starts to go down after that. That's from feedback inhibition. Okay. What if I could block that? And that means after day 7 or 8, what's going to happen to GnRH levels? Cesar. Now, it's supposed to go down, but if I block that, then it goes back up. Everybody understand that? That means after 7 or 8 days, GnRH starts to go up again. Now you're having a menstrual cycle within a menstrual cycle. Yes. You're blocking the feedback inhibition of FSH and GnRH. So hopefully everybody's following. We're on day 10. So near day 10. So estrogen goes up for about 7 or 8 days and then starts going down. That's feedback inhibition. And I said, what if we could block that feedback inhibition? That means GnRH will start going back up after 7 or 8 days. That means now you're starting another menstrual cycle within a menstrual cycle. This is how a drug called clomiphene works. Clomiphene used to be the most effective ovulatory drug on the market. The way it works is to block the feedback of estrogen on FSH and GnRH. That means GnRH will start up again. That means after 7 or 8 days, guess what? You got another egg that's going to ovulate. After 7 or 8 days, you got another egg that's going to ovulate. That means within one cycle, you may have 3 or 4 eggs ovulate. That means 3 or 4 chances to get pregnant. You understand that, Halima? You understand that, Ashley? But the bad side is all 4 of them can get fertilized. Multiple gestation is the #1 side effect. I was on call tonight. We had a woman who gave birth to 5 of them. 5 of them from one cycle. She fertilized all 5 of them. So, of course, they're all premature. So we took care of all 5 of them. All 5 of them survived. Typically, when you have 5 like that, we estimate 2 or 3 are going to die. And 2 may survive. But all 5 survived. So it was made the literature, made the news, everything. The last time I saw them on CNN, all 5 graduated from college. They had severe cerebral palsy, but their mind was completely intact. Yeah, man, it was so nice to see that. It means we did a good job. Nobody had brain damage. So it was great. So anyway, that's how clomiphene works. Multiple gestation is the #1 side effect. Clomiphene now is no longer the most effective ovulatory drug on the market. Letrozole is. The one I just gave you, a aromatase inhibitor. Letrozole is now #1. Clomiphene has dropped down to #2. Leuprolide now is #3. So if you want to induce ovulation, for in vitro fertilization, those are the drugs that we use. Any questions so far? All right. Now, let's go back a moment before I go to my ovulatory phase and talk about puberty. Because we talked about the first sign of puberty for a female was what again, Chris? Chris was a C? The first sign of puberty in a female? Breast buds. So we're going to go through the Tanner staging of puberty for boys and girls. Okay. And then talk about what if things go wrong, like precocious puberty. Okay. So Tanner staging. I have a way to remember this. I call a tap them. You want to tap them. This is the 4 phases of puberty. So T is for thelarchy. Has breast bud development. That means thelarchy precedes everything else. A is for adrenarchy. That means the adrenal gland suddenly wakes up, starts producing testosterone. That's what then causes pubic hair development. See, pubarchy. And then before you know it, that androgen gets aromatized estrogen. That's how you get menarche. So it's just a good way to remember what order things should occur. So that if anything goes out of order, that's how you know something's wrong. You always got to know what normal is to catch an abnormal. So tap them are the 4 phases of puberty that any child's got to go through. That's between the boys and the girls. Okay, Tanner staging. Dr. Tanner, pediatrician, came up with this Tanner staging for breast development and pubic hair. And on the exam, they'll just give you the physical exam for some little girl and ask what stage she's at. All right. So first, big picture. Was it growth spurt? For the girls, Tanner 2. Remember, the girls go before the boys. For the boys, Tanner 3. So any question about growth spurt? The girls go before the boys. Tanner 2 for the girls, Tanner 3 for the boys. Menses. First period for a female, Tanner 3. And the overall rule is puberty should start by age 13 or I'm concerned. That means when you start working children up. If puberty has not started by age 13, I'm concerned. That's when I start working them up. And menses should happen by age 15 or something's wrong. You start working them up. Because they'll give you a 14-year-old, a 14-and-a-half-year-old. The answer is no, wait till after 15. That's when you start working them up if they haven't had a menses. The rule is menses should occur within 2 years of pubertal changes. So notice puberty by 13, menses by 15. So if some little girl started by age 12, then by 14, I should be seeing menses or else I'm concerned. Any questions on that? That's the big picture. All right, so Tanner staging. I'm going to do breast and pubic hair. Now, all this is in your notes. Just follow along. That way, in case you have any questions. But you don't have to write anything I'm saying. Just follow along. Tanner 1 for the breast. All right, prepubertal nipples. That means before even the breast buds come in, it's Tanner 1. Once you get breast buds, read Tanner 2. That means you just entered puberty. Tanner 3, areola comes in. Notice that's when she should menstruate. So once I see areola come in, I'm asking mom, has she started her periods yet? Because they should coincide. All right, so areola. Tanner 4, secondary mound. That means you can feel some more breast tissue underneath that areola. That's Tanner 4. And then when it separates from the chest wall, Tanner 5. Those are 5 stages you want to know. You understand, Abdullah? Fanta, do you understand that?
Yes, sir.
All right, good. So those are 5 stages for breast development. All right, go to pubic hair. Tanner 1, no pubic hair. Tanner 2, sparse is the word they'll use. That means one here, one over here, one over here. Sparse pubic hair, Tanner 2. Tanner 3, a patch. That means now you actually see a patch of pubic hair around the base of the penis for a male, on the mom's pubis for a female, but it's a patch. Tanner 4, the whole area is covered with pubic hair now. That means the entire base of the penis is full of hair, but the female, the entire mom's pubis is full of hair. Now you're Tanner 4. And Tanner 5 is when it touches the medial thigh or rises above the pelvis, the pelvic brim. Then you're at Tanner 5. So again, like I said on the test, they'll give you the physical exam of a child and ask you what Tanner stage the person's in. That's why it's worth looking at this to make sure you know it. Because we use it a lot in peds. Any questions on that so far? So the next point then is called precocious puberty. What if it happens too early? Puberty used to be 12 and 13. And just a little more than 30 years ago. Now puberty is 11 and 10. 11 for the boys, 10 for the girls. That's the average age. It's not supposed to fall 3 years in just one generation, but it has. Why is it falling so fast? Because all the additives we have in our foods. We give growth hormone to everything now, chickens, pigs, goats, cows. So it's accelerating everything for us. And then for the female, obesity causes her puberty because that's where estrogen's coming from, adipose tissue. So because it's puberty, you got to think of the standard deviation. Standard deviation is 1 year. So for the girl, 10 is normal. That means if you have puberty before age 8, see 8 or below, that's because of puberty. For the boy, 9 or below, it's because it's puberty. Everybody understand? If you know what normal is, just subtract 2 years. That's because it's puberty. Okay? Any questions on that so far? All right. Once you're precocious, the question is why? Is it coming from the pituitary? We call that central. Or is it coming from peripheral tumor? We call that peripheral. How do we know which one it is? First thing we do is a Luprolide challenge. We give you GnRH injection. That GnRH should affect your estrogen if you're a female or affect your testosterone if you're a male. If it affects it, we check it tomorrow. The levels have changed. I don't even care if it goes up or down. It changed. That means up here is controlling it. Because my GnRH can only affect what's going on up here. It doesn't go to ovary. It doesn't go to any place else with a tumor. All right. It can only go up here. So if that testosterone estrogen changes, folks, the answer is central precocious puberty. That means this person is going through real puberty and is having way too soon. So what do? Keep that person on GnRH. But now it's a consistent level. Remember, it's suppressive if you give it consistently. We just use the surge just to see if it changes the levels. Once you realize it's central, they stay on GnRH until the appropriate time to go through puberty. Like the little girl I told you guys, I think, she came in age 6. She had 10 or 3 breasts. She had curves in her waist. I'm like, good Lord. And I'm present, grandma, what's going on here? Anyway, mom was in jail, so we didn't have any history from mom. I said, I said, grandma, she's about to menstruate. I'm seeing 10 or 3. She's about to menstruate. What does a 6-year-old girl know about menses? Absolutely nothing. She's still playing with dolls. All right, so that's why we had a mess on our hands. Okay, how do we deal with this? GnRH. We just put on GnRH, stop the whole thing. That way she wouldn't go through it. That means menses would not occur for another, we'd wait till it's about age 12. Okay, now we'll let her go through. And we stop the drug at that time. But that's how you treat central precocious puberty. Yes, sir. I'm giving a GnRH antagonist on a consistent basis. That will actually suppress the pituitary. It's going to stop puberty because she's going through it at age 6. It's too soon. So it's going to halt their growth, but they'll do catch up growth once you stop it. So they'll still grow normally. Yeah. All right. So that's how we treat central precocious puberty. What about if GnRH didn't make a difference in the hormone, then it's peripheral. That means you got a tumor somewhere or the hormones come from someplace else. For little girls, the most common cause is adipose tissue because obesity is #1 cause. Blacks and Hispanic girls right now, the average age is about age 8. Yeah, why? Poverty. Did I tell you about adipose? It's just poverty. It's not about race, okay? All right, because of puberty is because of just poverty. You're eating too much junk food, you get obese, and you start producing all this estrogen we cannot control, and that's why we're seeing precocious puberty happening to a lot of girls, okay? The problem is these little girls, they still have the mind of a little girl, but the body of an 18-year-old. The sad part is some of them come in pregnant because they don't know what they're doing. Why? Because they have the mind of an 8-year-old. I remember when I was on the OB rotation, we had an 8-year-old girl come in pregnant. Now, I remember I overheard the residents and the nurses calling her a slut. I said, listen, aren't you concerned about who the hell screwed this little girl? Why do you think she's the bad person? I say, you got to be careful. But that's the way they felt. Oh, she's a slut. Like, 8-year-old don't even know what a slut is. I said, 8-year-old girl, she just liked the attention some 18-year-old guy gave her. The 18-year-old guy sees the body of an 18-year-old. She still has the mind of an 8-year-old. So guess what? It's easy to get her to take her clothes off because she just likes the attention he's giving. So she has no idea the consequence of getting pregnant. You know, so it's not her fault. I always say, well, why don't you guys go after the 18-year-old? I mean, of course, now they do. That's called rape. Yeah, that's called rape. You can't just get her pregnant and just leave her to have a baby. But that's what was happening for a long time. Okay, so be careful so your prejudices don't come out because this little girl, if she's pregnant at age age 8, somebody did something bad to her. You know, even if it was a guy who was trying to be nice to her, you shouldn't be sleeping with an 8-year-old. Something's wrong with you if you're sleeping with 8-year-old kids. Okay. But anyway, that's why you got to know how to deal with it. Put them leuprolide till the proper time, let them go to puberty. What about if it came from the periphery? Then you figure out where it came from. I'd say if it's an obese female, you already know where it came from. If they want a tumor, what tumor produces a whole lot of estrogen, Jess? Granulosa cell tumor. See, granulosa cells produce estrogen. Yeah, so if they want it to be an ovarian tumor, then I know exactly what they want. Okay. For a male, where would you get a lot of testosterone? Number one cause, adrenal insufficiency, 21 hydroxylate, followed by 11. You've already heard it all, folks. The key is apply what you already learned. That's how you know. That's the number one cause. So Sertoli latex cell tumors producing testosterone, man, that's rare. That's rare. CAH is number one. Over 90% of cases is CAH. Yeah, always go for the number one answer before you look for anything else. Okay. All right, that's puberty and progressive puberty. Any questions on that? All right, Adam. Why do we do bone age? Yeah, you can do a bone age on somebody. You look at her chronological age. Let's say she's 13. I look at her bone age and it says 11. You know, so that means she has not started puberty yet. This is somebody where you're trying to figure out why come they haven't started growing yet. Well, let's see if they started puberty yet. If the bone age lags behind their chronological age, it just means they haven't gone into it yet. You do nothing, just follow them. They'll go into it. What about if the bone age matches the chronological age? That means they are in the middle of puberty. But if they're still small, that's called constitutional short stature. Your parents made you short. Nothing I can do about it. You can, but it'll turn out bad. We used to give them some growth hormone injections. All they did was accelerate their growth. So now they're tall children, but short adults. Because they will only go through the growth that they're not supposed to go to. So if they're supposed to be 5'6", they'll get to 5'6" much faster. Now they're tall children. We don't like to do that to people. Because when you're a tall child, guess what? People make fun of you. And now you're a short adult, they start making fun of you again. So that's why our treatment made no benefit. So we don't do that anymore. Okay. So that's how you decide whether it's appropriate height or not. That's usually for short stature. And, you know, here they are at puberty, but I'm wondering how come they're still so short? Is it because they haven't gone to puberty or they have gone into puberty and this is just their normal constitutional height? Nothing you can do about it. The other place we look at the growth chart. If they're perfectly in the middle of growth chart, you don't have to do anything. That's constitution. It's their parents. It's genetic. Okay. So that's when bone age can help you. All right. So any questions on that? Now, in the first 2 or 3 years, when a woman starts puberty, okay. Let me see. Should I do that first? No, I'll do that later. Let me go through ovulation because it plays into what I'm about to talk about. So, all right, here we go. Day 10 to 14. Who knows when day 10 is? It's called your pineal gland again. Pineal gland knows when it's day 10. It says, wait a minute, we need to ovulate. So there's like 7 things that have to happen for you to ovulate. That's all your notes. Just follow along. Pineal gland, number 1, goes to the ovary, so to speak. He doesn't actually go there. He goes to the ovary and says, okay, ladies, there's 10 of you developing. I only need 1 of you. 1, what are we going to do? All right, pull straws. Whoever gets the long straw gets to say, the other 9, don't worry about it. We'll take good care of you. And they don't know what that means, but they thought there's coffee and donuts coming. All right, so they draw straws and 1 egg named Mildred. I got the long straw. All the other ones, oh man, Mildred won again. Man, you know she won bingo last Sunday, right? Now she won this one too. Man, she's lucky. Yeah. And then all of a sudden, you got coffee and donuts? Yeah. A guy's bringing it. And the guy shows up, just handsome as all heck, man. Just debonair, man. Camera's flashing. But he got a big deal on his t-shirt. And they're all looking, ooh, he's so handsome. Okay, well, what is job? Plant phosphatidylserine all over their backs, right? Because then all of a sudden, they're gone. All right, gone by apoptosis. All right, and then 1 egg is left. Everybody understand? That's just all that is just event number 1. Pick 1 graphene follicle. There it is. The other 9 are now gone. Second event is to develop the graphene follicle. We have to go through 3 stages of development. 3 stages of development. Stage number 1, this is all still number 2 event. Stage number 1, cellular proliferation, but no antrum. Now I'm giving you the short version. They got a whole paragraph full of crap. I don't even read that stuff. You say proliferation of cells, I don't see any antrum in there. I said, good. It's a primary follicle. I don't care what else they say about that because they'll give you the staining and chromosomes, all that. You're reading too much. Cellular proliferation, but they don't mention the antrum. That's a primary follicle. Small antrum, secondary follicle. Large antrum, that's your graphene follicle. Because, Kathleen, your graphene follicle says, here's the ovum, like this, a big space, right? And then the egg, which the ovum started here in the middle, is now attached to the side, hanging on like this, waiting for permission to ovulate out of there. That's why you have all this clear areas called the antrum. So when it's a small antrum, it means the egg is just starting to move. And when it's a large antrum, he's now hanging on the side. All this tissue's been dragged with him. So all this is clear area now. Everybody understand so far? That's all event number 2. Event number 3, the graphene follicle starts to produce large amounts of estrogen. That's why you see another surge of estrogen. If we go to this graph, let's see. See that? Oops, sorry. Go back. All right. You see that? You see an initial rise in estrogen. That's caused by all 10 follicles developing. Look at this bigger surge. This is a graphene follicle. 1 follicle makes more than when 10 are making it. Okay, but they'll ask you to explain the 2 peaks. First peak is done by all 10 follicles. Second one is done by the graphene follicle because this is a bigger cell now and makes huge amounts of estrogen. Any questions? That's event number 3. Graphene follicle starts to make huge amounts of estrogen. Event number 4. The estrogen by the graphene follicle now stimulates LH receptors on the granulosa cells. Because up until now, I've never mentioned there was LH receptors on there. That's because it's usually controlled by FSH. There's not supposed to be LH receptors on the granulosa, but starting from day 10 to day 14, I'm just going to put 2 of them. Suddenly you see LH receptors. What's going on? The graphene follicle is getting that egg ready for pulling the egg out of there. Remember, LH causes ovulation. You need receptors for that. That's the job of estrogen from graphene follicle. Any questions on that? So this is all, again, event number 4. Stimulates LH receptors on granulosa cells. And also stimulates LH receptors right here on the theca externa. I never said anything about theca externa until just now. There was no LH receptors there before. Now there is. They 10 to 14. That's how we know pineal gland is controlling all of this. And then the estrogen from the granular, sorry, man, I'm trying to make sure I'm saying the right word. From the graphene follicle. So these are all caused by estrogen from graphene follicle. He's going to go to hypothalamus and the pituitary and actually stimulate GnRH to come to rise. What? Yes. That means at day 10, GnRH starts to rise again. Remember, it's feedback inhibition till then. Now it's feedback stimulation. So again, we know it's got to be pineal gland controlling this. There's the same receptor, which you have to reset the action when the estrogen binds it. And this is estrogen specifically from graphene follicle. Regular estrogen couldn't do that. Okay? So now you get GnRH starts to rise. That means LH and FSH will start to rise. But who's going to rise faster? LH. Why? Because FSH has to overcome, remember, feedback inhibition. Estrogen feedbacks inhibit FSH. Nobody feedback to inhibit LH. That's because there's no rise, no big rise in progesterone in the first 10 days. So progesterone doesn't need time to surge. So this is explaining the LH surge, which is event number 5. They love to ask, how do you get this? Okay, so again, estrogen feeds back to stimulate GnRH, which then stimulate LH and FSH. But LH will surge faster than FSH because FSH was under inhibition from estrogen for the first 10 days. So you have to shake off the inhibition before you can stimulate it to come out. So he lags behind LH. And that's how you get the LH surge. Any question on event number 5? Event number 6, now that we have LH receptors on the theca the granulosa cells. LH is surging at day 14. LH then grabs that ovum and pulls it out of there. And that's where my picture, that's where this picture is from. The egg pops out of there now. And now you got an egg sitting out here. Back at the ovary, what do we got? An empty pocket, which is really the theca externa. Now we call them corpus luteum. All you do is rename them because there's no ovum here anymore. Just a pocket. So corpus luteum. Any questions there? Now, that means every time that happens, you can easily get a luteal cyst. That means what if that egg didn't pop out there? Then it'll still inflate like a little balloon, but then the egg never popped out. So we call that a luteal cyst. If it enlarges so fast, Kathleen, as to cause bleeding, then we call it a luteoma. So luteoma is just a luteal cyst full of blood. Again, these are all things that happen during the menstrual cycle for a female. What do we do with both of these? Nothing. Leave them alone. Because remember, we don't want to carve out anything off that ovary and then cause scarring. That's going to mess up some other eggs. All right. So only, again, when it gets big enough and it becomes uncomfortable enough, that's about the only time you can justify cutting it out of there. Typically, it's got to be like more than 8 centimeters. That's huge. It's almost like, yeah, that's big. So 8 centimeters in size and causing a lot of discomfort, then we'll cut it out of there. Otherwise, just leave it alone. Okay. Now, after this corpus luteum is made, you got LH receptors on the theca externa. All of a sudden, LH now leads to progesterone production by the theca externa. But these LH receptors just showed up between day 10 and 14. Once you ovulate, that progesterone is now allowed to be secreted into the bloodstream. And that's how we smoothly go into the luteal phase. Is that sweet or what? Wow. Physio. Good stuff, man. All right. Any questions on how we made that transition? So that's our 7 events. So the 7th event is that the corpus luteum, theca externa, now starts producing progesterone. And that progesterone now pushes into the luteal phase. So 7 individual events must occur between day 10 and day 14. All 7 events are time sensitive. That means before day 10, you don't see it. After day 14, you don't see it either. That's how we know pineal gland controls all 7 events. Any questions at all? All right, let's go to what happens if something goes wrong. As always, start with normal first. Then what if something goes wrong? So luteoma and luteal cyst we already talked about. Oh, sorry, Leslie, you go ask me a question first.
Can you explain me again, like why FSH get low because the feedback inhibition?
Yeah, in the first 10 days, after about day 8, estrogen already did its 3 actions. Estrogen feedback to inhibit FSH because that's her signal. It was also feedback inhibit GnRH because that's her signal as well. So that means there's feedback inhibition after day 8 on GnRH and FSH. And that's why that has to be overcome after day 10 before FSH can start to rise. And that's why LH rises first and faster.
Okay, got it.
Yeah, that's how you get the LH surge. All right. So now, when the woman when she ovulates, we have fancy terms for it. We call it metal schmerz. Metal schmerz. Metal schmerz is also known as mid-cycle pain. So the times I've seen the question is a female who always complains about a little discomfort in her flanks. And they say about the middle of her cycle, about 2 weeks after the last menses, that's the middle of your cycle, or 28-day cycle. You got to realize that's just a mid-cycle pain that every little girl gets. I mean, obviously for a teenager, she doesn't know what it is until mom explains it to her. That's normal. Metal schmerz is normal. So she can be sitting at Starbucks, sipping on a latte for $7.50. And then all of a sudden, while she's talking to her girlfriend, all's on, ooh, girl, I think I just ovulated. Okay, it's not that pronounced. I'm just making stuff up. But but some women can tell you the exact moment and exact minute that they ovulated. It is that significant that they can tell you that they just feel a little twinge, enough to make her, oh, that's ovulation. But she knows that's normal for her. That's metal schmerz. Any questions on that? All right. Now, after you ovulate, you're supposed to go through the luteal phase so you can menstruate. In the first 2 to 3 years of puberty, a lot of young girls go through the estrogen phase, but they don't ovulate, which means you cannot menstruate. Everybody follow that? If you don't go through the last stage, you cannot menstruate at the end. So if you do not ovulate, you do not menstruate. So we have the word called anovulation is a problem. Anovulation is the most common cause of primary amenorrhea. And then we'll talk about secondary amenorrhea. Anovulation. Notice how something that's normal is the most common cause of abnormal. That's why I keep saying, make sure you know your normals. That's where all these abnormal stuff is coming from. Okay? So anovulation means she's going through the estrogen phase, but then she doesn't ovulate, so that means no menstruation. That happens so frequently in the first couple of years that it is the most common cause of primary amenorrhea, meaning she's never had a period. Now, remember, that's primary. Secondary says she used to have a period, now she doesn't have one. Okay. With primary amenorrhea, we always still do a pregnancy test, but that's not the most common cause of primary amenorrhea. I want to make sure nobody picks that when they ask, what's the most common cause? Don't pick pregnancy. Okay? It's anovulation. How do we prove it? We prove it, Ashley, by giving her progesterone, synthetic progesterone. I'm going to make her body think she's going through this last phase right here. It's Provera. It's called a Provera challenge. It's progesterone. Provera, 5 milligrams for 5 days. So easy to remember for the step 2 and 3, 5 for 5. And then you suddenly stop. Notice for a female, when progesterone suddenly goes away, that's the end of her cycle. She should bleed. So the progesterone challenge, Provera, 5 milligrams for 5 days. And then you stop. On day 6 or 7, she should bleed. If she does, then it's anovulation is the answer. You don't have to do anything. You give her reassurance. Say, Mom, this is normal. A lot of little girls have this problem, but eventually she's going to menstruate. It's just an immature HPO axis. I've seen it written that way too. That's the same thing. It just takes a while to get everything all synchronized. Now she's bleeding every month. Any questions on anovulation? Progesterone challenge is how we prove it. You give her Provera, stop it on day 6 or 7, she should be bleeding. What if she does not bleed? Then anovulation is not the problem. Everybody understand? That means she doesn't have an estrogen phase either. Everybody understand the conclusion, first of all? Remember, if you have the estrogen phase and you don't ovulate, you cannot go through progesterone phase. Well, I'm going to provide you the progesterone phase, and then you should bleed at the end. That's how I know anovulation is the problem, because I've just proven it to myself that there is an estrogen phase because you responded to my progesterone. But if you do not respond, that means you don't have estrogen phase either. You understand it, Halima? You understand it, Anam? If you don't have the estrogen phase, then I need to work up your pituitary and your ovary. One of them is not working. So hypothalamus, pituitary, ovary. Which one should I look at first? You start with the ovary. What's the best test to run to see if the ovary is working? Nave. The man Saba. Not the estrogen. Just remember this, folks. We don't normally measure the hormone coming out of a gland. You measure the signal to the organ. Physiology, you cannot fool physiology. So if you don't have enough ovarian function, FSH should rise. So we check FSH next. If the FSH is high, where's the problem, Angie? The problem's no, not pituitary, ovary. The signal for pituitary is going higher, which means ovary is not responding. See? There's too many things that affect the hormone levels. That's why we don't check the hormone. Be careful. That answer is always on the list, but that ain't the answer. Measure the signal to the organ. You cannot fool physiology. Physiology knows what time of the month it is, knows what she's doing. And at FSH, if it stays normal, then everything's fine. But if FSH rises, that means that ovary is not working well. Anna. Yeah, that means ovarian insufficient. That means the ovary is not working. Yeah. Yeah, streak ovaries will give you the same problem. Yeah, like in Turner's, the ovaries doesn't work. So we check the FSH. If it's high, then we know it's the ovary. Then you go ahead and evaluate the ovary with an ultrasound. If it's low, then we know it's up here, hypothalamus and pituitary. Then we scan your head. You see, that way you understand the management because it makes sense. That's why I say learn the physiology and biochemistry of things rather than just learn how to manage things and yet you don't know how they're coming up with this stuff. Okay? Any questions on primary amenorrhea? What about secondary amenorrhea? Let's say, Jess, your friend calls you and say, you know what, girl, I'm so glad you're in medical school because you know I have my period every month on the 15th. I can set the calendar. But you know, the last 3 months I haven't had a period. With your wisdom and physio, can you please tell me what could be the problem? She's pregnant to rule otherwise, no matter how fancy to make it sound, folks. It is pregnancy or to rule otherwise. So now we run a pregnancy test first because that's the most common. Remember, the first one was just because we just want to rule it out before you start doing things with radiation in it. But it's not because it's one of the most common causes at all. Anderson. Immature, either you say ovarian insufficiency or immature HPO axis, which means hypothalamus pituitary ovarian axis and ovulation. Yes, Anna. Yeah, go through the same steps and try to figure out where the problem is. That means, is it ovary, pituitary, or hypothalamus? And then you respond to whatever you find. Paris? Is anovulation, which causes amenorrhea. Because you can have amenorrhea without anovulation. That's why I'm showing you it's two different things, but one causes the other. Yeah. Anovulation happens first, and that's why you're not having menses. That's amenorrhea. So anovulation is therefore the most common cause of primary amenorrhea in a teenage female. Any questions on that? Now, what if?
Excuse me.
Who's this? Is that Mabel?
Yes, sir.
Okay, what's your question, Mabel?
Please, sir, did you say that when the FSH is increased is ovarian problem?
Yes.
Then when it's decreased is coming from where?
Hypothalamus and pituitary.
Thank you. So you also said that the amenorrhea will come before ovulation.
No, anovulation happens first. We see it as amenorrhea. If she's not ovulating, she's not menstruating. So she comes in and complains, I'm menstruating. And then you get a history that says, oh, she's never menstruated. But that's because she's not ovulating. Once you finish working her up, then you find out anovulation is the cause of it. But that happens first before you get to amenorrhea. Okay. But it doesn't mean amenorrhea causes anovulation. It's the other way around.
Excuse me, doctor, I have a question regarding
Go ahead, Leslie.
Steps. So I always thought that you do pelvic ultrasound first to check if a uterus is present, because if the uterus is not present, you go forward to karyotype to know if it's a man or if it's a girl. All right.
Yeah, right? You can do that.
Okay.
That's if they want to start down there, but you're right. If you have any reason to suspect it, yeah, then check the uterus. Okay, and then karyotype if the uterus is not there. That means there's a genetic problem if the uterus is not there. Or it could be Mullerian agenesis. You didn't have Mullerian duct to even develop a uterus.
So if I have the uterus present, then I go to FSH.
Yeah, right.
Okay.
So all I'm talking about right here is just the amenorrhea part. Now, if you want to see if the person has a uterus, so that means on physical exam, you should be able to feel it. If you don't feel it, okay, then we start down there and say, how come I didn't feel a uterus? Then you can start your workup down at the bottom. Yes. If you've done your physical exam and she has a uterus, then it's not a uterus problem. Then we go progesterone challenge. Do the what at that time? You can do it after that. So meaning if you do, what was the step you just said? Yeah, if you do progesterone challenge and you don't get any bleeding, then you can say, okay, well, let me just check and make sure she even has a uterus. You can do it then too if you want. Yeah, that's how most of us did it, but now some people just do the ultrasound first. I don't like to start doing tests when I haven't really finished evaluating the person. I'd rather do it afterwards. All right, so that's amenorrhea. Now, what if this cyst stays here? And then the next month, another cyst develops. Then the next month, another cyst develops, but you're not ovulating at all. So the extreme of anovulation is called polycystic ovarian syndrome, PCOS. Why is it so common now? Because it's all over the literature, folks. Because obesity is causing it. Why is obesity causing it? Because adipose tissue is producing so much excess estrogen, it messes up the whole pituitary axis. And all of a sudden now, a lot of normal women stop ovulating and then develop PCOS. That's why PCOS is so common now. Okay, it's caused by obesity. So let's go through how this happens. Whether you developed a cyst and then stop ovulating, or you were obese and then developed cysts and stop ovulating, either way. The most common presentation is oligomenorrhea, that means fewer periods than usual, or secondary amenorrhea, it just stops altogether. Does everybody understand that part? I'm going to show you how to talk it out without memorizing any of this stuff, okay? Because one day, all of a sudden, you're not ovulating anymore, but you were ovulating last year. That's why it's secondary amenorrhea, because all the woman comes in and says, I haven't had a period in 6-8 months. What's going on? Then you check her over, you see about a bunch of cysts all over the place. You say, oh my gosh, she got PCOS now. All right, so the presentation first. Oligomenorrhea or secondary amenorrhea. Everybody understand that part? Okay? If you're not ovulating, you cannot get pregnant. That's why, and you can't have menses either. All right, so now she shows up to you. So what you got is all these cysts that develop, but none of them opened up like that to allow the egg out. Everybody follow? So presentation. Within each cyst are the precursors to progesterone. Remember, that's what the ovary is supposed to release, progesterone, right? Well, if you got a cyst, then that means the precursors to progesterone are trapped in here. They never got out. But eventually, by concentration gradient, they're going to start leaking out. Remember, concentration gradient guides everything. And once they start leaking out, what do you got? The masculinization effects, because progesterone is androgenic. That's why all of a sudden got increased muscle mass, increased appetite, increased weight gain, polycythemia, hypertension, right? Obesity, which then leads to diabetes. Sound familiar? Everything they write about PCOS. Okay? So what's going on here, Sabu? What's going on is the precursors are all steroids. Remember, progesterone is a steroid. And steroids break down proteins and take the amino acids and make what out of them? What do you do with the amino acids? Steroids, when they break down proteins, they put the amino acids into what cycle? Gluconeogenesis. That's why they have hyperglycemia. That's why they have insulin resistance. That's why they get diabetes. And what drug do you know, Sabu, can block gluconeogenesis? Because you've learned it very well. Metformin. Why do you think metformin is a drug of choice for PCOS? That's what I say, folks, learn your normals. Abnormals are easy to explain, but if you don't know what normal is, you try to write down and memorize everything about abnormal. Now realize there's an easy way to understand all that stuff. And you don't even have to memorize it. You just got to know what normal is. So we got presentation. All right, now we got all the signs and symptoms. Let's look at labs. They love to ask about labs. So hyperglycemia, I just explained to you. Hyperinsulinemia, I just explained that too. That's how to get insulin resistance. And then if you got insulin resistance, like a diabetic, after hyperglycemia, what do you get? Hypertriglyceridemia. See that? Same thing we talked about in biochemistry. Once one goes up, the other one's going up after, because glucagon controls both of them. You understand, Nola? Understand, Kathleen? All right. Then the other thing they want you to check, folks, is LH over FSH ratio. If you're not releasing progesterone, then there's nobody feeding back to inhibit LH. That's why LH rises much higher than FSH. So LH over FSH ratio of 2 to 1 or greater. Again, so we got glucose, triglycerides. All right, we got high insulin we can check. We can check LH over FSH ratio. These are just labs they like to test you on. Any questions on that? Now, the question then becomes, how do we manage this thing? Well, obviously, if she's obese, the first thing is get her to lose weight. If she qualifies for bariatric surgery, get her in there. Okay, because this is only going to get worse. If she's not, first thing to do, hang on, let me just finish this. If she's not obese, the first thing you need to do is stop her periods altogether. Gloria, how do I block your periods? Say it. It's called OCPs. OCPs, first line. That doesn't work, Leuprolide, just the same way we did it before. You can't block it from the periphery, block it from the top. Leuprolide is next. And then when she gets ready to get pregnant, And now what can we do to help her ovulate smoothly? Take what off? Take what off? Take the OCPs? That won't work. She's not ovulating. Is there a drug we can give her to help her out? I said we'll help you. No, that's not first line. GnRH lupuli is third now. What do you do first? I give you guys the drugs for ovulation. Why don't you just follow that? I know. Yeah, letrozole is first drug, then clomiphene, then lupuli. All right, that's it in order, folks. Always look for the in order. I told you the best trap is the one you pick an answer, but it's out of order, so you never got a point for it. But you thought you did. All right, so you got to know things on. Letrozole is now the best ovulatory drug. Clomiphene is now number 2. Lupuli is now number 3. And you're going to learn later, HCG is number 4. It's the least reliable. And that's what we do. Whenever she's ready to have babies, give her one of those medications, pop, pop, pop. 3 or 4 of them will finally ovulate, and then she gets pregnant with 1, that's it. And then we put her back on OCPs after she delivers the baby. Yes. Good question. Does any information shows that bariatric surgery increases fertility? Slightly does, yes. I was just reviewing that a few weeks ago. Yeah. So bariatric surgery, if you get her to lose the weight, there was a slight increase in fertility. Even metformin. When you give them metformin increased the ovulation rate. Yeah. It's just not reliable as an ovulatory drug, but it did clearly increase in the study. Okay. Isis, you have a question?
Yes, Dr. Francis. Could you repeat why in PCOS the patients gets hyperglycemia? I'm sorry, I didn't follow you when you were explaining.
Hyperglycemia is from the precursors for progesterone. They're all steroids. Remember, progesterone is a steroid hormone, right?
Correct.
Yeah. So 17-hydroxyprogesterone, 17-hydroxypregnenolone, DHEAS, they're all androgenic steroids. But steroids break down proteins and put the amino acids into gluconeogenesis. You understand that?
Okay. Yes.
That's how you get hyperglycemia. And then after you get hyperglycemia, what do you get? Hyperlipidemia. And now you got insulin resistance. And then before you got diabetes. It's all straight out of biochemistry. You mess one up, the other ones get messed up too. Yeah, no problem. Syed, question.
Question regarding letrozole. So I was a bit confused. I think earlier you said it can be used as an OCP, but how can it also like be used to as like a?
No, letrozole is an AI, aromatase inhibitor. It's not used as an OCP. It's used to induce ovulation. It's not used to suppress anything.
Oh, okay. Maybe it was like for the endometriosis, was it, or?
Yeah, it's to suppress estrogen production by adipose tissue, though. It doesn't suppress your period.
Oh, okay, thank you.
Yeah. Question, Stephen?
Yeah, I don't understand the day 10, if you're secreting estrogen, you think that stimulates GnRH. Isn't everything a negative feedback?
Yeah, remember, estrogen is a feedback to inhibit FSH and then to inhibit GnRH only in the first 10 days. I told you between day 10 and day 14, the probably again recess those receptors. Now it's stimulatory. That's how you get GnRH to surge. That's how you get LH and FSH to surge, but LH surges faster. Pineal gland will reset what those receptors will do. The response is totally opposite. Now you're going to stimulate GnRH to come out, and FSH and LH will come out. Rather than feedback to inhibit in the first 10 days, all of a sudden now it's doing something different. Only between day 10 and day 14. Otherwise, it's feedback inhibition. Yeah, that's how we know it's time sensitive, which means pineal gland controls it. All right, let me see. So we've done an ovulation. All right, now let's go into the luteal phase. So everybody understand? Hang on. Let me remind you of my transition. What have I done? I've gotten through the 7 events that occurred between day 10 and day 14. I've ovulated, and now theca externa, which is now called corpus luteum, is producing progesterone, which is why we're going into the luteal phase, because progesterone then controls the luteal phase. All right, Mabel, your question.
So you said that for ovulation induction, we have to give some medication. What is the 4th medication that you called?
For what?
For us for induction of ovulation, you called
Induction of ovulation. I just gave you the 4. Did you catch any of them?
Yes, yes.
What was the first one?
I need the first one is Repro. Is that?
Letrozole is number 1.
Okay,
right.
letrozole, then
Clomiphene is
clomiphene
number 2.
and leuprolide.
Leuprolide is number 3, and ACG is number 4. That's the 4 I gave you.
ACG. So what is ACG, please?
The ACG for pregnancy, human chorionic gonadotropin.
Okay, it said ACG. I was like, what is okay?
Okay, ACG is the same one as test for pregnancy. All right, so
Okay.
now we're going into the luteal phase. Progesterone takes us in there. Let's look at the 3 things progesterone will now do. Read. No, let me forget on Sandra first. So Sandra, we're going into the luteal phase. That means it'll go to the breast just like estrogen does, but look what it does, increase glandular growth. You understand that? This is why for a female, therefore, her breast will enlarge in size because you're stimulating the glands to enlarge. That means the breast has to enlarge. The breast will always enlarge in the 2 weeks before menses in a female. This is why a female will start complaining about breast tenderness in those 2 weeks because the glands are enlarging. That means they're pulling on her bra straps quite a bit and it hurts. Okay, now you know. What if I stimulate the glands too much? Then they'll inflate into a bubble, which we call a cyst. That's why a cyst is the most common breast mass. This is from the neoplasia lecture. Now you know how it got there. This always explains why too much of that causes fibrocystic disease. Most common breast tumor after age 25. Now you know why. If you stab one of the cysts for fibrocystic disease with a needle, what color is that fluid, Nolan? Yeah, green. Remember, it's therapeutic and what's it, diagnostic at the same time. If it's green and the bubble go down and stay down, there it is. You've proven the diagnosis. We don't do anything else after that. All right, but anyway, I just want to show you how it got there. Glandular growth. This is why a female put on all these IUDs, which are progesterone only. Why do you think they complain about breast tenderness? Now you know why. Any questions on that? Yes. No, this is luteal phase I'm in now. I'm done with ovulation. Yeah. No. During the ovulatory phase, it's just ovulation. Yeah. The other 3 areas are not doing anything different. Now we're entering the last 2 weeks. That's progesterone. So we go back to the 3 places and see what it does. Glandular growth. This is why pregnant women increase their breast size. This is how one of the ways a mother in Nigeria knows when a little girl is pregnant. Because the little girls will say, no, mommy, I'm not pregnant. You should see my girl, put out your hand. You liar. Without she can see, I'll tell you about the line that tell you you're pregnant, but the breast, she knows what size your breasts were last month. Why they're bigger this month? Mom knows you're pregnant. Because we don't have no big ACGs in Nigeria. We live in the forest, man. So moms know those. I'll tell you, moms know everything in Nigeria because they're forced to know because they're too poor to run their daughter to a clinic. The nearest clinic is hours away. So we don't run them anywhere. But it's amazing how those mothers know you're pregnant. All right, so that's one of them, glandular growth. All right, then look what else it does. Endometrium. It stimulates coiled arteries. All of a sudden, you got a bunch of coiled arteries in the uterus. All of a sudden, it's oozing blood. See that? Getting ready for menses. See it? Arteries start producing more RBCs. The progesterone that's high has the sequence of erythropoietin in it. The woman makes the extra RBCs that she's about to lose every month, which makes sense. Otherwise, every woman would be severely anemic in just a few months. Okay, but she actually makes the extra blood that she's about to lose, which means the net should be right back to baseline again. Okay, coiled arteries. And then what else? Deposition of lipids and glycogen in the wall. Why? To get ready, blood supply and food for the fetus in case she gets pregnant. So it is progesterone's job, Melissa, to prepare the way for that fetus. I need blood. I need food. Burgers? No. Lipids and glycogen. Fries? No. Lipids and glycogen. So in other words, the uterus is now engorged with blood, lipids and glycogen. You understand, Melissa? This is what we now call the endometrial stripe of pregnancy. When you do that first ultrasound, why do you think we're measuring endometrial stripe? That you want to see if the endometrium is thicker than usual. That means, oh, she's already preparing for implantation. She's definitely pregnant. But on the test, they'll just say thick endometrial stripe. I just want you to know what that is. It means you're pregnant and implantation is, the wall is getting ready for that implantation. What if I give you an implant, that's Norplant, Explanon, or IUDs, they're all progesterone. What's going to happen to the uterine wall, Solange? Thicken with what? Lipid, glycogen, and coiled arteries. So watch my hand. Oh, let me zoom in a little bit. Hey, come on, come on, come on. Okay, here's the uterine wall. And then all of a sudden you give that person progesterone. And then here comes the coiled arteries coming through the uterine wall like that. That means they outgrow the uterine wall and start spraying blood into the uterus like that. You know what that's called? Breakthrough bleeding. Huh? It means that coiled arteries are breaking through the wall like that. That's what breakthrough bleeding is. That's the number one side effect of every progesterone contraceptive. Mirena, Skyla, Loletta, all of them. You know, Nexplanon, all of them. Norplant, all of them. Breakthrough bleeding, number one side effect. I just want you guys to understand what breakthrough bleeding really is. Okay, that's the coiled arteries just popping out there. Well, if the bleeding gets real bad, we got to do something. We got to do something, Zena. Watch my hand again. Here's the wall. Here's the coiled arteries. How can I get this wall to start proliferating and therefore cover up the vessels so that bleeding will stop? Progesterone doesn't stimulate proliferation. Match it up to word. Cynthia? Constriction doesn't match up either. Maria? It's called estrogen. Look up the treatment. IV estrogen for 3 to 5 days. Look at that. I told you it's all from basic physiology. But that's not what's being taught to physicians. That's the part I can't stand. They always just tell you that's the way that we do it. That's the way we do it. No doctor ever seems to know why we do anything that we do. All right. That's why we do a lot of things wrong. If you don't understand what it is you're doing, after a while, one day you're going to forget it. And then you just wing it and do something else and somebody gets hurt. Okay. All I got to do is talk it out. That's why I talk it out a lot, folks. Talk it out. That way I can see the physiology again, and then I can come up with the therapy because I now understand it again. Solange. Is this why some of the oral contraceptives can make you fat? Let me tell you what the literature says. The literature says that weight gain is not a problem. But when you ask the women who are on it, half of them say, no, they gain weight. Okay, and that's what she's telling you. Do you gain weight? Are you wondering what? Yeah, I'm telling you, there's no way that literature can fool me. I'm telling you, how many women I've talked to gain weight? You telling me it doesn't? Here's what that means, just so you guys understand what it means. It means when they did the study, because they did a study, and what they do, half said we gain weight, half said we don't gain weight. Guess what? It was a wash. And that's what they're talking about. But they don't tell you that's what they mean. That's statistical. It doesn't cause weight gain. Not that nobody gains weight. It's just that when you use statistics, it's a zero. Yeah. So there's no way they can convince me. Oh, but I got to tell you that because on the test, if they say, well, yeah, the answer is you don't gain weight. You got to pick that answer. I'm just telling you. But in the real world, yeah, please. If a woman calls me and says she's gaining weight, I say, yeah, it's those pills I just started you on. Yeah, that's normal. Your key is to be open with her. Because otherwise she's going to stop taking the pills. Once she gains too much weight, she says, no, I don't like these pills. And that's it. She stops the pills altogether. Now she doesn't trust anything else you want to put her on. Yes. Progesterone stimulates appetite. That's what I'm saying. There's physiology behind all of it. That's what I'm telling you. That's why when they say, oh, it doesn't cause weight gain, I'm like, okay, how are you figuring this out? And then when I looked at them, oh, okay, it's just because half said this, half. I said, now I know what they're talking about. But that's not the real world. The real world says, yeah, you may gain weight, but just call me if you think it's too much. Okay? Then we lower the progesterone. But anyway, we've done endometrium, and let me make sure I've got everything covered. Yes. No, one more thing. Hang on, let me just make this other transition. Here's the things you need in the endometrium to implantation occur, right? So what if I were to block that implantation? Does everybody understand, Oxy, that you can't get pregnant? Everybody follow that? Emergency contraceptives. Mifepristone. Mifepristone is what is it? Progesterone receptor blocker. That means, yes, you had a lining, and then today you don't have a lining anymore. That's because I can make it disappear. Mifepristone is also known as RU 486. I'm sure you guys have heard it on the news. Why? It came out of Europe, and when it came here as birth control, the Right to Lifers said, oh, no, that's not birth control. That's called an abortion. And it is an abortion. So they moved into a chapter called abortifacients. But it's one of the drugs you can use, Plan A. Or you can call it morning after. That means the earlier you use it, the better. It's good for up to 72 hours, but it's best used in the first 24 hours. Yes. No, 11 August is coming up. There's no longer, there is a way to make it morning after, but this was the original morning after pill. Yeah, this was the original one. Yeah, 11 August, that's what I'm going next. This is Plan A. This was Plan A. Now, I didn't say Plan B, this is Plan A. So Plan A was come in as early as possible. I will give you this thing that block progesterone receptors. That way, if you did get pregnant, the baby has nowhere to implant and it will just spontaneously abort. Everybody understand that? So that's why now it's listed as an abortifacient. Okay, Mifepristone. What about Plan B? Plan B is levonorgestrel. How was this developed? In the old days, doctors always thought things through and came up with a way to help women. So let's say you missed your period and you think you must have got pregnant. All right, the doctor would tell you, okay, take 2 of those progesterone pills I gave you right away, and then repeat it in 12 hours, which means you got a big surge of progesterone in these 24 hours. Everybody follow? And then tomorrow, no more pills. Yeah, her body thinks she just came to the end of her cycle. She'll slough off tomorrow. It was a way to force the lining to slough off. That means same thing. And that's why it's called Plan B, because this was the second one they came up with. Okay. Levonorgestrel works all the way out to 5 days, but best used in the first 3 days. Just like mifepristone works in the 3 days, but best used in the first day. Okay. Some new ones now called ulipristal. Ulipristal. I might be off by a letter, but you'll recognize it. Ulipristal is a progesterone receptor modulator, is the way they say it, which means just like tamoxifen relaxant, it can block the receptor. That's all you're doing, just like mifepristone. And ulipristal works all the way out to 5 days too, but best used in the first 3 days. Now, you can also use the IUD, copper IUD, as a emergency contraception. So copper IUD can now be used. How is this going to work? That means if she had sex last night, let's say it's a Sunday, and she comes to see me on a Monday, I can just implant the copper IUD. What's it going to do? Cause inflammation right around the cervix, so that any sperm who tries to pass that area will just die, just dissolve in the liquid. 99.8% effective. Copper IUD is now able to be used as contraception for an emergency. Leslie, you were first?
Yes, I have a question of the mechanism of levonorgestrel.
Yeah, levonorgestrel is high progesterone. A company just saw what doctors were doing. They didn't even test it. They heard doctors were doing this. 2 pills when I see you, 2 pills in 24 hours, in 12 hours, tomorrow nothing. And you will start sloughing off the lining tomorrow. So what they did was put all 4 doses together as 1 pill and say you can do the same thing with this 1 pill now.
Yeah,
And it worked.
I have when I was doing my OB-GYN rotation, Plan B was very expensive. It's very expensive. So the doctor just make patients take all the OCP pills from the packet, and it's cheaper and it's the same.
Much cheaper. It's the exact same thing. Yes. See, that's what I'm saying. And because my partner and I, we serve the poorest part of the city, you got to think of ways to do the same thing as what the FDA is telling you. And it's cheaper because I'm helping people who are poor. They can't afford the expensive pills. And so you just say, take 2 of these and then do the same thing in 12 hours. If I see you in the morning, I'll say, okay, 8 p.m. tonight, take another 2 pills. And that's much cheaper than going out to get one of these. Okay. Yeah, but it's the same exact thing. That's how the company got that idea. Yes. Why is there weight restriction? Oh, good point. I'm about to do that in a second, but weight restriction is weight restriction on all OCPs. I think the upper limit is 50 No, BMI of 50, I believe is what they said. That means if the person is that heavier than that, that means they got so much adipose tissue. What does that mean? Fat soluble hormones, like the one I'm about to give you, is going to be sucked up into the adipose tissue. I can only give you so much before I hurt you with it. That's why they say, okay, certain weight limit, don't give any more than that. That means let's try something else. Yeah. It decreases efficacy because adipose tissue is sucking up all the hormone. Yeah. No, without weight loss. Yeah. All right. Wait a minute. Jess was next. Since progesterone increases spiral arteries, yes. Why do we get bleeding or do not get bleeding? Yeah, if you give progesterone only, that's all the IUDs. All of them are progesterone only. All the implants, progesterone only. Breakthrough bleeding is one of the most common side effects. No, it's temporary. That means if your body sees this going on, eventually the body will respond by having this happen. But I can speed that up by just giving you IV estrogen. Okay. Yeah. So that otherwise you can never use just progesterone only contraceptives if bleeding was that heavy, it was that bad. Typically, the breakthrough bleeding happens in the first 1 or 2 months. After that, the body's figured out what to do and just stops it, and then they get used to it. That's why only when it's severe, they actually even end up in the emergency room with it, and then we hospitalize them for IV estrogen. So you accelerate a natural process. All right, question, Mabel?
Sir, please, I have 2 questions. Please, did you say that we should use a levonorgestrel at the first 2 to 7 days, 37 days?
No, I said 5 days. I've never said 7. I said it
Okay.
works for 5 days, but it's best used in the first 3 days. Same thing with ulipristal. Works out for 5 days, best used in the first 3 days. Copper IUD is best used the day after. Put it in so the inflammation starts right away before that egg migrates down. And therefore, before the sperm can even come up, that's it.
Okay,
They
so
all
that means
die.
in copper IUD, if somebody have sex today, tomorrow you can fix the copper IUD,
Yeah,
right?
you can put the copper IUD tomorrow to stop her from getting pregnant. And it works. Okay. All right. Now, if everything goes well in the cervix, progesterone thickens the mucus. Why? Because now she's ovulated. There's an egg that can be fertilized. So she wants to put a barrier between her and that sperm. That means if the sperm try to come through, it's going to stop right there at the cervix and die. This cervical mucus is so thick, it keeps out 99% of sperm. When they figured that out, what did the company do? What if I just wrap progesterone around your cervix? It's called all the IUDs. Progesterone, Mirena, progesterone. Loletta, progesterone. Skyla, progesterone. Folks, that's how they figured it out. When they realized, oh, the mucus is thick enough to keep out 99% of sperm, why don't we just put an implant in there with just progesterone, and now we call it an IUD, just progesterone. Or implant, Norplant, Nexplanon, same thing. The thing is the mucus. But the benefit of the mucus in a normal female is that it keeps out 99% of germs as well. It has to really keep the germs out, but it also keeps 99% of sperm out. So that's why I like when a woman is pregnant, close to delivery, notice that mucus plug will fall out. She can tell you the day it fell out. That's because it stayed there after she got pregnant to protect the baby all 9 months, make sure germs can't get in there. Okay, and that way when she's ready to deliver, it'll pop right out. Okay, so that's how all those IUDs work. Then next issue is, wait a minute, I want to make sure I didn't get her. No, okay, that's IUDs. Any questions on those? All right, because let me just make my transition to birth control, because that's where I'll take it after lunch. Birth control says, I want to stop you from getting pregnant. If I want to stop you from getting pregnant, Meha, that means I got to stop you from ovulating. If you don't ovulate, you can't get pregnant. Does that make sense to everybody? And how can I stop you from ovulating? What hormone is responsible for ovulation? Huh? LH is. So what hormone would feedback to inhibit LH? Progesterone. So Meha just told you how all birth control pills work on the market. It's the progesterone in the OCPs, folks, that stop the pregnancy because they block LH, feedback to block LH. Without the LH surge, there is no ovulation. There's no egg to fertilize. And that's why OCPs or all the hormonal contraceptive methods, 99.8% effective. Now they're calling them LARCs. That's why I left the two words in. Long-acting replaceable contraceptives versus short-acting replacement. The pill is short-acting. Teenagers love the pill. I mean, a lot of older women like the pill too. But the rate of pregnancy with a long-acting, 0.2. No, not 0.2, 0.02, sorry, 0.02. That's very small. And yet it was 7% with the short-acting. That's a no-brainer, folks. That's a huge difference. That's why they're encouraging every physician to push towards the LARCs for women, but don't tell her she needs to take it. Let me just tell you this before we break. If this is for the guys, listen carefully. If you tell a woman what birth control to use, 90% will never use it. Why? Because women get offended if you tell them what to do with their bodies. So just letting you know as a man, just don't make that mistake. That woman would never listen to you after that. That's what they found in a study, 90%. They don't like a doctor telling them what to do. You can suggest it, but don't tell her you should do that. Never say you should. I think you'll be, or some doctors become so, especially if it's a poor woman. Well, you need to stop having babies. You don't realize your prejudice is coming out. And you're telling her you need to do something about having all these babies. That's it. She'll never do it because you're trying to make her do something with her body and you don't have that right ever. Okay. So be careful. And after lunch, I'll talk you through what the article said about how to get a woman started on birth control without getting yourself in trouble. All right. Because again, you don't want to try to make somebody do something and in the end, they didn't do it. That means all that effort you just put through was for nothing. Cynthia. Suggestive vasectomy works for me. No accidents here, babe. After 2, I said, I'm done. Tie it, burn it, cut it. Shit, man, I don't care. That way, no mistakes. I don't hear about no mistakes. I'm done. Okay. Having children are expensive, man. I don't know how people have 4, 5, 6. Jeez, that's a lot. If they want to have a baby, adopt. Adopt. That's what I said. I said, I'll adopt if I change my mind. Yes.
Will you adopt me?
Will I adopt her? Maybe wants to be adopted now. Okay. I said, what's your question? No, how they get pregnant? Nothing works 100%. That's all you can say. Yeah, nothing's 100% proof. So that's why there's always a chance that still everything goes well and goes around the hormones. Yeah, so let's stop there. Abdullah, you had a question. Last question. Hang on.
Yeah, with the copper IUDs, if it's increasing inflammation, can't that lead to scarring eventually?
Oh, good question. Can a copper IUD cause scarring of the cervix? Well, the copper itself causes a gentle inflammatory fluid to build up around the cervix. They've got women with IUDs in Europe, 30 years and counting. They have never taken it out. Okay, it works. You can leave it in as long as you want. America says 10 to 12 years. That's just to make money. It's got nothing to do with medicine. Okay.
Also, can it
But
cause?
wait a minute, let me just show you give you the data. And these women who've been on it for almost 30 years now, they found no increased incidence of cervical stenosis from scarring, like you thought. The inflammation is so mild, it doesn't cause scarring, it causes stenosis. No increased incidence of ectopics, no increased incidence of STIs, no increased incidence of UTIs or fetal loss. None. 30 years worth of data, folks. 30 years. So just so you know, that data is out there. All right, so a good place to stop. Any other questions? Let's stop here. Stop back at 120.